to develop good rehabilitation in the future. So then welcome back after the break, Dan, and I'm really excited to hear more about mechanisms and etiology. Please.
Good. Thank you. So both Winfried and myself, I think, tried to convince you of the fact that the people who meet criteria for fibromyalgia are the tip of the iceberg, and that you really need to look below the surface, because the majority of individuals that you'll see in clinical practice with this problem will not necessarily carry the fibromyalgia label, nor should they have that as their most prominent diagnosis. So what I want to do is show you how powerful subthreshold fibromyalgia is as a concept. So you might, based on the conversations this morning, sort of think, well, maybe it is sort of important or somewhat important to identify someone who has a score on that fibromyalgia measure that is not quite 13, because though 13 we know would meet criteria for fibromyalgia, but maybe I should treat someone that has a 9 or a 10 or 11 a little bit like I treat a fibromyalgia patient. Well, I want to show you some data that suggests that you should go even further, that you really should look at this fibromyalgia measure and where people are on this continuum, because it seems to be highly predictive of what treatments are going to work and not work when we're seeing individuals with chronic pain. So I'm going to present some studies that were done at the University of Michigan in the last 5 years that were led by Chad Brummett. Chad is an anesthesiologist that's a mentee of mine that just won the annual award in the American Society of Anesthesiology for the best young investigator. And he's done some really nice work looking at the fibromyalgia measure in the perioperative period. So our hypothesis in these studies was if someone has a condition like osteoarthritis of the knee, and we're about to replace their knee because we think their pain is coming from their knee, if we gave these individuals the fibromyalgia measure right before they had their knee replaced, and use this measure to see where they are on this continuum of how much of their pain is coming from their knee versus how much of their pain is coming from their brain, that the higher someone scores on this fibromyalgia measure, the less likely they would get better if we replace their knee. But also what I'm going to talk a lot about in this session is opioids. Because the kind of pain that we're talking about here that's coming from the brain, narcotics and opioids don't work to treat this type of pain. It is inherently insensitive to these classes of drugs. I'll show you some data that shows this, and then I'll show you some imaging studies that show you why that might be the case. So in these large studies, the studies that I'm going to present now are studies of people with osteoarthritis of the knee that either got their knee replaced or their hip replaced. So this was hip and knee osteoarthritis. In the studies that I'm showing, you had about 700 people that got either knee or hip replacement surgery that we followed then for a year after their surgical procedure. We followed them in the first 2 days after their surgery to see how well the opioids that were given to them right after the surgical procedure worked to treat their pain. And then we looked to see how much pain relief they got 6 months after their knee replacement surgery or their hip replacement surgery. In these individuals, we looked at all the other things that had ever been shown to predict either a good or a bad outcome in knee or hip replacement surgery. We looked at whether they were anxious or depressed, whether they catastrophized, which is another construct that's been talked a lot about in the pain field. But basically looked at everything that had ever been shown to either predict a good or a bad outcome in knee replacement surgery. And the only new measure we put in all of these studies was the 2011 fibromyalgia criteria, which, as Winfried showed, can be scored from 0 to 19 based on how many body sites you have pain, and from 12 more points based on how severe the fatigue, the sleep disturbances, and the memory problems are. For each 1 point increase in someone's fibromyalgia score, they needed 9 milligrams more of oral morphine equivalents to control their pain in the first 24 to 48 hours of their hospitalization. They were 25% less likely to have a 50% improvement in their pain 6 months after the surgical procedure. And the thing that was surprising to us, and we've seen this over and over and over again in our data, and I know Winfried has seen very similar things in his data, is this fibromyalgia survey measure was linear, starting at a score of 0 and going all the way up to a score of 16 or 18, that for each 1 point increase in fibromyalgia, people needed more opioids and were a lot less likely to get better if we replaced their knee. But the difference between someone that went from a score of 0 on the fibromyalgia scale to 3 was the same as someone who went from 12 to 15 that was in the fibromyalgia range. And a point of emphasis is all of these phenomena were largely independent of classic psychological factors. We measured anxiety, depression, catastrophizing, and only about 25% of the variance in the fibromyalgia measure could be predicted by all of those other psychological measures measuring anxiety, depression, and catastrophizing. So the two things I want to emphasize is this fibromyalgia measure is linear, starting at a score of 0 and going up in predicting opioid responsiveness and surgery non-responsiveness, and it's largely independent of classic psychological factors like anxiety, depression, and catastrophizing. So here is a histogram with the individuals in this particular study, and you see here on the x-axis here is the fibromyalgia score going from 0 to 31. You see that about 8% of the individuals that got knee or hip replacement surgery at the University of Michigan actually would meet criteria for fibromyalgia. There were 55 of those individuals in this study. 0 of them had the diagnosis of fibromyalgia in their chart. So none of these people, and this is at the University of Michigan, which is arguably the best fibromyalgia research center in the world, is that none of these 55 individuals that were diagnosed with fibromyalgia. They were all diagnosed as having osteoarthritis and acting as though this was the only problem that these people had. But let's, for example, or just for point of emphasis, imagine that even before we did these studies, you would have intuitively thought that if someone with osteoarthritis met criteria for fibromyalgia, they wouldn't respond as well to knee replacement surgery and they wouldn't respond as well to opioids. So now I'm going to show you two different individuals, neither of whom has fibromyalgia, but they both have different fibromyalgia scores. This is patient A and patient B. Neither of them has a score of 13. So neither of them has fibromyalgia. They both have osteoarthritis of the knee, but one has a higher fibromyalgia score than the other. If you compare patient B to patient A, patient B needs 90 milligrams more of oral morphine equivalents to control their pain in the first 24 to 48 hours of their hospitalization after they get their knee cut open. And they're 5 times less likely than patient A to get better if we replace their knee. These are not subtle findings. These are really strong findings that you should be using in making clinical decisions about whether you operate on someone, whether they're going to respond well to an opioid in the perioperative period. And again, neither of these individuals has fibromyalgia. Both of these would have whatever you want to call it, different degrees of fibromyalgia, subthreshold fibromyalgia. But this concept goes well below the tip of the iceberg. It's important to look below the tip of the iceberg because it's still a very powerful construct, even well below the threshold we would use to diagnose fibromyalgia. And again, another point of emphasis is that most of these people over here don't meet criteria for any psychiatric disease. They're not anxious, they're not depressed. They don't have any of these classic psychological factors that we have always thought are just part and parcel of fibromyalgia. The psychological factors play a very prominent role in people with fibromyalgia scores of 20, 25, 30, 31, 32, people that feel the need to put extra things in their scores, but they're not playing a very big role at all in these people with subthreshold fibromyalgia, and yet you see how powerful this construct is and how it's actually independent of these psychological factors. Knowing someone's fibromyalgia score doesn't just tell you what isn't going to work, it tells you what is going to work. The drug duloxetine is a drug that raises serotonin and norepinephrine in the brain. And serotonin and norepinephrine are low in the brains of people with depression, so the first clinical condition that duloxetine was used to treat was major depressive disorder. But it then became clear that duloxetine worked fairly well as an analgesic, and it was subsequently approved for use in the United States in neuropathic pain, low back pain, and osteoarthritis, because the trials showed that duloxetine worked in conditions like low back pain and osteoarthritis, even though it's working in the brain. The more recent studies have shown that if you give a group of low back pain patients that body map before you give them duloxetine, the people that have pain sites other than the back, the more widespread their pain is, the more likely duloxetine is going to work. It worked 60% better in people who had low back pain plus 5 or more other sites of pain around their body, which is very common in people with low back pain, than it worked in people with low back pain alone and just a single site of pain in the back. And this has now been published in the last couple months. I have forgot to put the most recent slide in, but this is now available for publication. And what we see is that subsets of individuals with any chronic pain condition sit at different points in this continuum of whether it's more of a peripheral problem on average or whether it's more of a central problem on average. But the point of emphasis is on average. In low back pain, most of the studies have suggested maybe 40% of individuals in a tertiary care spine clinic will meet criteria for fibromyalgia. So what you could say is that it's about halfway in between it being peripheral and central. But a point of emphasis is at the level of an individual, it's not 50-50. Some of those individuals with low back pain have an entirely peripheral problem, some have an entirely central problem, and some have a mix of peripheral and central factors that are both contributing to their low back pain and that we have to treat both. And so you can't look at what the average amount of fibromyalgia or central sensitization is in a cohort of chronic pain patients. You have to look at that person that's in front of you with that diagnosis of low back pain or Ehlers-Danlos syndrome or fibromyalgia or osteoarthritis, and you have to say, what is the evidence that there's ongoing nociceptive input? What is the evidence that there's nerve damage? And what is the evidence that there's central sensitization or fibromyalgia? Because each of those underlying mechanisms needs to be treated separately, because the treatments are different for nociceptive pain than they are for neuropathic pain than they are for centralized pain. So when I talk about the pathophysiology of centralized pain states, the first thing I would say is we need a better term, because this isn't just pain. Whatever this is, fibromyalgia, central sensitization, it's way more than pain. It's fatigue, sleep problems, memory problems. There's a lot of stuff going on in the brain of these individuals other than pain. In many individuals, this starts in childhood. You can see this start to occur in childhood, especially the top-down form of fibromyalgia that's really more of a brain disorder. I firmly believe that if we really want to make a dent in preventing the 50-year-olds with really terrible fibromyalgia that there's nothing that we can do about, is we have to identify them when they're in their teens or their early 20s before they have 30 years of maltreatment and mistreatment and untreatment, because once they get there, they're really hard to treat. But if we were to identify people in their teens after they have their second regional pain condition, when they're in their late teens or their early 20s, to me that is a blinking neon light. When someone has a couple different places of regional pain by the time they're 20 years old, that's a blinking neon light to me. They're on their way to developing fibromyalgia if I don't do something about it. And the thing that we really should be doing to these young individuals is get them involved in the non-drug therapies, get them in cognitive behavioral therapy, get them in exercise programs, get them into the non-drug programs so that they realize this needs to be a habit throughout their entire life, or else they are going to become the fibromyalgia patient that none of us can do anything about. But the way we identify this is that people will have pain in different regions of their body over the course of their lifetime. And the problem right now is that people don't take a good history of this. And again, now I will make fun of orthopedic surgeons because there's none in the audience. I would do it even if it was all of you were orthopedic surgeons, because I love arguing. But now it is important for that orthopedic surgeon, when they see that person with knee pain, to ask them, have you had pain in other areas of your body over the course of your lifetime? And if they look more like that body map I showed you on the right than the one on the left, they should be reflective and wonder whether that surgery is really going to help that person, because the fundamental problem in that person is in the brain, and the orthopedic surgeons haven't yet learned how to operate on the brain to make the knee better. And so that isn't going to work. Operating where the pain isn't going to work if the fundamental problem is the brain. Another set of symptoms that I want to talk about, because this really is turning out to be important biologically, is that the brain, if someone asked me, what is the brain region that is most involved in causing fibromyalgia, the first answer would be there's a lot of them, and there's certainly not just one brain region that causes fibromyalgia or causes pain, but a brain region called the insula. The insula is a brain region that helps code for the intensity of sensory stimuli. If you have a low activity in your posterior insula, then you have a low volume control setting or low amplifier setting in your brain, and you don't feel much of what's going on in your periphery. But if you have a high volume control setting in your insula, because your glutamate is high in your insula, which is the major excitatory neurotransmitter, or your GABA is too low in your insula, which is the major inhibitory neurotransmitter. If you have a hyperactive insula, you don't just have a high amplifier setting for pain. You think lights are brighter, noises are louder, you have a lot of side effects of drugs. These individuals are sensitive to any type of sensory stimuli, because that is what the insula does, and that really seems to be a key part of the neurobiology of fibromyalgia. Tor Wager is a researcher at the University of Colorado, and last year he published a couple studies showing that if you just took the functional MRI images of people with fibromyalgia and healthy controls, and you mixed them up, and you use machine learning to try to say, you gave that machine an fMRI and you said, is this a fibromyalgia patient or is this a control? He said that with 92% predictive ability that you could tell the fibromyalgia patients from the controls. I don't quite believe it to be 92%, because we do a lot of brain imaging, but it's over 80%. It's really, you can really tell a lot on brain imaging, and the brain imaging sequences that are the best at differentiating a fibromyalgia patient from a non-fibromyalgia patient is when you not only give them painful stimuli, but you give them bright lights or loud noises, and you look at the way they sense those stimuli. And again, the insula has a lot to do with that. The insula really seems to be a big area where the volume control setting for a number of different sensory stimuli sits in the central nervous system. We already talked about how common this is. I'm just going to go quickly through a lot of these slides. But the reason that people don't understand how common this problem is, it goes by a bunch of different terms. You know, we call it fibromyalgia, irritable bowel, interstitial cystitis, tension headache. We use all those terms that are called functional somatic syndromes. But if someone gets the same problem as fibromyalgia after they're deployed to the Gulf War, we call that Gulf War illness. It's the same problem. There's overwhelming evidence that the veterans that come back from war with this exact same symptom complex have the exact same problem, but we use different names, so we don't see it as being the same problem because it's a different set of terms. In these patients with rheumatoid arthritis and lupus that have fibromyalgia as a comorbidity, we don't call it fibromyalgia. We call it lupus and rheumatoid arthritis. But if you look in aggregate at all the different places that fibromyalgia hides, it might be the most common disease seen in humans. And I will go out on a limb saying that, is that if you look at subthreshold fibromyalgia and you look at all the different things people go to general practitioners for, where you can't find an alternative cause for it, a lot of it is within this spectrum or within this continuum. So if you, as a GP, the better and better you get at identifying this, and by the way, I don't care what you call it. I agree that a lot of people don't like the term fibromyalgia in the United States. Fibromyalgia to some people will always be the F word. And I'm okay if people don't want to use that term. If you want to use the term central sensitization, if you want to come up with centralized pain disorder, come up with your own term, call it whatever you want. But understand that the better you are at identifying this phenotype, even when it's not like the end of the continuum fibromyalgia, the more nuanced you'll be looking at your patients and saying, I have to use some exercise in this person, some cognitive behavioral therapy, a little bit of a tricyclic drug, but because that's actually more so what I'm treating rather than the disease that the label that person has when they're coming into my office. And so, again, if you look at just the people who meet criteria for fibromyalgia, the new criteria identify about 5 or 6% of the population. The old criteria identify only 2% of the population. And neither Winfried and I explicitly said this, so I will say this now. One of the big advantages of the new criteria is they'll identify this fibromyalgia phenotype in men. And it's very common in men. Using the new criteria in the United States, fibromyalgia is only 50% less common in men than it is in women. It's 2/3 women and 1/3 men, and that's about the ratio of every chronic pain condition. Almost every chronic pain condition is 1.5 to 2 times more common in women than in men. And why is that? Because women's brains are more pain and sensory sensitive than men's brains. Women don't develop any more damage in their knees, or they don't develop any more damage in areas of their body. They feel more because their amplifier setting on average is higher than a man. Man, I didn't cause this. I'm not a misogynist. I'm not a sexist. I'm just reporting this. If it wasn't annoying enough to be a female in this regard, if you're still actively menstruating, you become more sensory sensitive in the premenstrual phase of your cycle. There's something about being a female that we don't yet understand causes females to be more sensitive to any type of sensory stimuli. And this can be triggered or exacerbated by a number of different types of stress. But I want to point out that fibromyalgia is extremely familial. The twin studies in fibromyalgia, going back to a question that was asked over there, the twin studies in fibromyalgia show that fibromyalgia runs strongly in families. And family members that have fibromyalgia will have all those other functional somatic syndromes in much higher frequency as well, and will have more of any type of chronic pain than people without fibromyalgia. They will have higher rates of psychiatric disorders as well. But again, what you really see cluster in the families are the different pain conditions and the functional somatic syndromes. Now, we don't know the specific genes that are driving this, and it's not a single gene. There are no single powerful genes causing fibromyalgia. Our group has recently done genome-wide association studies of 30,000 people where we have the fibromyalgia measure filled out, and we have GWAS data, and there is not a single strong hit that comes above the significance level. So this is going to be like body height. Body height is incredibly familial, but it's hundreds of genes together that lead to your body height, not any single genetic thing that you can tell how tall someone is going to be. And it's clear that that's what we're seeing here with fibromyalgia. It's an example of a condition that is extremely familial, but there's not any single strong genes that are really driving this. It really seems to be polygenic. And this can be triggered or exacerbated by a number of different types of stressors, and this might be one area where Winfried and I don't entirely agree. But let's just say, for sake of argument, that a lot of different types of things that happen to people in life that you could characterize as stressors seem to be capable of putting people at higher risk of, or of immediately thereafter developing or triggering the development of fibromyalgia. And it's virtually everything: major surgical procedures, being deployed to war, major traffic accidents, all sorts of bad things that happen to people make it more likely that later in life they're going to develop a centralized pain state or fibromyalgia. And so once we see that this occurs, there is a fairly specific neural signature, especially on functional MRI and functional imaging, that we're starting to hone in on in people with fibromyalgia. Again, I don't quite agree with Tor that we're 93% there, but we're 70, 80% there with respect to seeing the different things on functional, chemical, structural neuroimaging, especially looking at connectivity between brain regions that seem to be driving this central nervous system process that I'm talking about. And I'll just talk a little bit about these top three things. Number one, what you see on functional MRI, that you can actually see that these people objectively are more sensitive to the brightness of lights or to pressure applied to their thumb. But you can also see that the degree to which different brain regions are either too connected to each other or not connected enough to each other makes sense with respect to what we know about pain processing. In most of the brain regions that turn up the volume control, the brain regions of fibromyalgia patients are too connected to each other. But the one area of the brain where you see there's not enough connectivity in fibromyalgia is you don't see enough connectivity to the brain regions like the periaqueduct gray, the locus coeruleus, where the origin of the descending analgesic pathways, the pathways that begin in the brainstem and go down and inhibit the upward transmission of pain. Those pathways in fibromyalgia are known to be diminished or attenuated on quantitative sensory testing, and then we can see on connectivity measures that there's not enough connectivity to those brain regions to cause that descending analgesic activity that leads us to not have pain when we're sitting in a chair for an hour or an hour and a half and 2 hours. By the way, if you don't know what a quantitative sensory test is, the length of time you can sit in a chair before your back and your buttocks start hurting is a quantitative sensory test. And I guarantee you, if we did a formal survey in here, on average, the women in the audience would start feeling discomfort on average before the men in the audience would. But it is a good measure, and I can tell, because I give lectures so many to chronic pain patients, I can tell how many of you are starting to have pain because you start squirming around when you're having pain after you're sitting for a prolonged period. But that literally is a measure of what your amplifier setting is and how pain sensitive you are. Because if you have enough activity down these descending analgesic pathways, you theoretically could sit for unlimited periods of time and not have any pain, because these pathways would not allow any of that information to go up to the brain to be felt as pain. So these are the first functional MRI studies that were done in fibromyalgia. They were done by our group when we were still at Georgetown. They were led by Rick Gracely, who's no longer with our group. He's at University of North Carolina. But all we really showed with these studies was when we gave fibromyalgia patients a low-intensity stimulus to their thumbnail of 2 kilograms, which they said hurt a lot. When we gave 2 kilogram stimulus to healthy controls, they said that doesn't hurt. That just feels like touch. And that's the definition of fibromyalgia. They hurt a lot more. So we put them in the scanner, and what we showed, without going into all of this here, is that the fibromyalgia brain looked the same when it was getting 2 kilograms of stimulus as the healthy control brain looked when it was getting 4.5 kilograms of stimuli. Is it not only did the patients tell us they hurt at much less pressure to their thumbnail, we could see on the functional MRI that the brain regions involved in pain processing were activated in the fibromyalgia patients even when they were getting that low pressure stimulus, whereas it took the controls, we had to give them twice as much pressure for them to start experiencing pain and for us to start seeing neuronal activation in the brain regions like the primary and secondary somatosensory cortices, which we know are involved in the localization of pain and the intensity of pain. These studies have now been replicated scores of times by different groups, and you don't just find this fMRI pattern in fibromyalgia, you find it in the subset of patients with low back pain or rheumatoid arthritis or osteoarthritis that have high fibromyalgia scores. This is a connectivity measure, and again, I'm largely presenting our group's data because our group was generally the first to do everything brain imaging-wise in fibromyalgia, but these studies have been replicated by a number of different groups now. And this one measure of connectivity, the degree to which the default mode network is a series of structures in your brain that are connected to each other when your brain is at rest and you're really sort of idling and not doing anything. But in people with fibromyalgia, there's a lot of connectivity between the default mode network and the insula, and that measure of how much connectivity there is between the default mode network and the insula is the closest thing we have to a biomarker of how much pain someone is experiencing. It has now been shown in low back pain, in irritable bowel syndrome, and in fibromyalgia that the degree of connectivity between the default mode network and the insula is actually a pretty good measure of how much pain that person is when they're sitting across the exam room from you. I hope that we don't start putting people in a scanner to see how much pain they have. I hope we continue to believe what they say. But if we chose to do that, we're not too far off now. What we can't do in a scanner is tell what someone's VAS scale is going to be. Because if you give someone a scale from 0 to 10 and say, what is your pain? Some people are going to use a 6, and some are going to use an 8, or some are going to use a 9. Different people will use different parts of the scale. But what you see is that if you put that person with fibromyalgia in the scanner when their pain is a 7, and then you put them in the scanner again when their pain is a 4, that difference between 7 and 4 of 3 is really reproducible from research participant to research participant, is we can really see when people's spontaneous ongoing pain goes up and goes down. This is the best measure. There's other measures that can help us do that as well. And then we can also look at the size and the shape of brain regions. Most of the brain regions involved in pain processing have a tendency to get smaller over time. The only brain region that seems to get larger as someone develops more widespread pain is the primary somatosensory cortex. Remember from when you went to medical school or nursing school, or if you didn't go to any of those schools, then you'll just have to take my word for it. The primary somatosensory cortex is the area of the brain that tells us where the pain is. And that area of the brain gets larger in people with fibromyalgia because what the body's trying to do is increase the size of that area, because people have so much pain that it's really trying to discriminate better where is that pain coming from in that person. But all the other brain regions actually have a tendency to get smaller. This is, by the way, I'll talk about this in a little bit. There are a lot of people that are saying that small fiber neuropathy causes fibromyalgia. I think that's totally stupid and totally false. It doesn't make any sense whatsoever. But our group has recently done a study where in rats, we showed that by increasing the glutamate level in the insula of rats, we could get the exact same changes in the skin of the rat that is called a small fiber neuropathy. And what we think is happening is the entire nervous system, when it has chronic pain, is responding by shrinking the nerves and the axons in the periphery, shrinking all the brain regions that are involved in coding for the intensity of pain. The only thing that's getting bigger as part of this neuroplasticity is the primary somatosensory cortex, because the brain is trying to localize that pain better. But it's exactly, if I had to guess what the brain would do, if faced with chronic ongoing pain, is that this is what all of the elements of the body try to come back towards homeostasis, and this is exactly what we're seeing in the nervous system in individuals with fibromyalgia. Now, someone asked about neurotransmitters. We don't know if these neurotransmitters are the cause of the fMRI changes and the connectivity changes, or they're an effect. One of the problems right now is we just don't know which of these things in the brain are most proximal and which are downstream of those. But you can identify abnormalities in all of the neurotransmitters that have ever been studied in fibromyalgia that are known to either turn up or turn down the volume control setting. They're all abnormal in people with fibromyalgia. So let me start first on the left side of the screen here. These neurotransmitters that are listed here are all neurotransmitters that have a tendency to increase the volume control setting. These neurotransmitters over here have a tendency to decrease the volume control setting, and you'll see that serotonin here can do both, depending on whether serotonin is binding to these receptors or these receptors. Serotonin can either increase or decrease the volume control setting. Now, those arrows are the direction of that neurotransmitter either in the spinal fluid or the brain of people with fibromyalgia. So a lot of the neurotransmitters that are known to increase the volume control are too high in people with fibromyalgia. And most of the neurotransmitters that are known to decrease the volume control are too low in fibromyalgia. So you see all of these arrows are going the direction that you would anticipate if these were somehow causing the increased volume control setting. High substance P, high glutamate, high new growth factor, low GABA, or low norepinephrine or serotonin. The only neurotransmitter system that is going the wrong direction in people with fibromyalgia is the opioid system. Our group has done a lot of work looking at the body's own internal opioid system, and the endogenous opioid system is actually hyperactive in people with fibromyalgia, But stick with me for a minute here. We think this explains why people don't respond to opioid drugs. So what we see in people with conditions like fibromyalgia is they have 2 to 3 times the level of endorphins or enkephalins in their spinal fluid as healthy controls. They're releasing a lot of their own endogenous opioids because they have a lot of pain. Well, the problem is those endogenous opioids are going and binding to their mu-opioid receptors, and if that opioid receptor is bound by an endorphin or an enkephalin, that oxycodone or morphine you give to the person doesn't have a binding site. And we think this is why individuals with conditions like fibromyalgia become less opioid responsive as they have higher degrees of fibromyalgia, and I'll show you that study in just a moment. But the bottom line is, and if any of you ever saw the movie This Is Spinal Tap, if you like the guitar analogy, then you can put your volume control at 11, because that was the amplifier setting. But literally this high amplifier setting seems to be driven by high levels of neurotransmitters that are known to increase pain and sensory sensitivity, and low levels of neurotransmitters that are known to decrease pain and sensory sensitivity. This is the study that I was alluding to that we recently published, where we did PET with a mu-opioid, carfentanil, at the same time as we did functional MRI, and it really looked like in fibromyalgia patients, the endogenous opioid system was driving the fibromyalgia, and that this is why I have been saying for 10 or 15 years, giving a person with fibromyalgia an opioid is like throwing kerosene on a fire. It is a really bad idea to give these individuals opioids. Now, sorry, I have to do another Trump thing. We didn't know this before we elected him, but he is one of the smartest people in the universe. He has an incredibly high IQ, and he tells everyone that he's ever comes across about how high his IQ is, and he really feels sorry for all the people around him that don't have as high of an IQ. This is his tweet. I didn't make this up, okay? But even given how smart he is, he didn't know that healthcare could be so complicated. He had no idea that healthcare could be so complicated. Well, so I recently got an article in the journal Pain that talked about the endogenous opioid system and said the same thing, is that this is one of the problems with opioids, is that opioids aren't just analgesics. Opioids make us happy. They control social bonding. They help sleep. They help stress. And this is one of the particular problems with giving a fibromyalgia patient an opioid. Even if you give them an opioid for acute pain, they're going to like the opioid, they're going to stay on it because of their depression, because of their stress, because of their poor sleep, and because of some of these other things. And this has really become, in the U.S., why we have such an epidemic of opioids in the United States, is that these individuals do particularly poorly with opioids, and these are the individuals that are at highest risk. If you give them an opioid for a surgical procedure, they're going to stay on that opioid and continue to take that opioid for longer periods of time. And so the last slide here is I just want to point out what was set up earlier, is that some of these individuals with fibromyalgia do have central sensitization. The ongoing nociceptive input is driving what's going on in the brain. And this was a nice study that showed that in people with fibromyalgia, with myofascial pain or osteoarthritis, treating the peripheral pain generator made the fibromyalgia better. And then this is really the last slide, just talking about the difference between these two different types of fibromyalgia, or these two different types of central sensitization, one of which is more top-down, that is more of a fundamental brain disease, and the other is more bottom-up, where it is being driven by what's going on in the periphery. And in anyone, but and especially in those individuals, you have to really make sure that you are identifying and treating ongoing nociceptive input. Thank you.
Thank you, Dan, for a hugely interesting talk, and I think that we all agree on that mechanisms are very important in understanding what fibromyalgia and related pain is all about. So we actually do have a few minutes for a couple of questions before lunch. So do we have any questions over there? We have a question?
Have you all used any buprenorphine partial agonist opiates so that you leave a little room on the top of the receptor for their own production? And is it effective?
Yeah, so buprenorphine, is that what you asked about? Yeah, so there's absolutely no data or evidence to support what I'm going to say right now, and I always use that disclaimer because I really try to use evidence and data. But if you have to use an opioid in someone with this problem, I really believe that buprenorphine or tapentadol, both of which are mixed opioids. Buprenorphine has a mixed agonist-antagonist, whereas tapentadol has a mu opioid with a norepinephrine reuptake inhibitor embedded in it, that I think those opioids would be better opioids to use for people with this problem than a pure mu opioid, because I don't think you'd be nearly as likely to get into this kind of problem that I've been talking about. And by the way, this type of problem really seems to especially occur with higher doses of opioids. I'm not really bothered by taking, people taking acetaminophen with codeine a couple times a day. That doesn't usually run into problems. Those aren't the doses of opioids we're using in the United States to treat pain. And those medium to high doses of opioids taken chronically for long periods of time, I think, do cause these problems I'm talking about.
So thank you very much for this very interesting talk. And we just discussed here in my part of the room, could this high level of opioids cause why low dose naltrexone could help?
Absolutely.
Thank you.
Yeah, we think that's... Now, I want to be clear about this. The people who did those low-dose naltrexone studies in fibromyalgia think that drug is acting as a glial cell inhibitor. We don't agree, but and it doesn't matter at some level if the person gets better. But we actually think the fact that low-dose naltrexone was shown, again, the studies are not great. They're small studies, but it's used fairly extensively in the United States based on those studies. And I actually do believe that it helps a subset of individuals. We think it's helping more so by blocking the endogenous opioid system and inhibiting a feedback loop rather than as a glial cell inhibitor, but only time will tell whether we're right or Jared Younger's right.
Yes, I have a question about the central mechanisms. Do you use any conditioned pain modulation to see the degree of endogenous problems in the control system? Do you think there has a use in the diagnostic or in phenotyping the different patients with fibromyalgia?
So the question was, do we use conditioned pain modulation? Conditioned pain modulation is something you derive from a specific type of quantitative sensory testing. The early studies of conditioned pain modulation looked like it was going to be a good mechanistic probe. The last 10 years, we do conditioned pain modulation on every research participant in all of our studies. It's virtually worthless. And the greater pain field of people that do quantitative sensory testing, they don't always acknowledge that in their articles, but when we get together in rooms and talk about conditioned pain modulation or quantitative pain testing, we all acknowledge that this measure, we're not sure what it tells us, it's not consistent. Part of it is because it's done in so many different ways by so many different people. But let me just say, as someone that's published a lot on CPM, I really am not sure what it's telling us. And I don't think it is good enough to incorporate into clinical care or clinical practice, because I think giving the fibromyalgia measure would tell you far more with a lot less time and a lot less effort than getting set up to actually measure conditioned pain modulation.
Now I have one final short question before lunch.
Thank you for a great speech. My question is, in Israel, they say that 7-8% of all kids have fibromyalgia. Are there any numbers in the US? Because earlier you said it's important to look at young people that they not develop fibromyalgia. And is there anybody who's thought about this growing pain? Many children, they have growing pain. May that be a part of fibromyalgia?
So again, I'll answer the last part of your question first. A couple abstracts that never ended up being published have suggested that growing pain is one of the things that often is an early indicator of someone moving on to fibromyalgia. But all the other childhood pain conditions are better established. Functional abdominal pain, headache, dysmenorrhea, any regional or widespread pain, including fibromyalgia in children, those children are much more likely to become adults with chronic pain. And this is when I talk to my pediatric colleagues, I think this is something that we have to really change. Is we teach pediatricians that those are benign pain conditions because they don't have an organic basis. The person doesn't have rheumatoid arthritis. Well, they're not benign. If you look at all the epidemiologic data and the studies, these are the people that we should be identifying early and intervening, again, especially with non-drug therapies, to try to help prevent these individuals from developing the fibromyalgia that we can't do anything about. But those studies haven't been done yet because, in part because pediatricians still, at least in the United States, view all of those conditions as benign conditions. They're happy to diagnose those conditions because that means I don't have to take care of that child because there's nothing wrong with them.